water.
Yeah.
Welcome, everyone. I'm Deborah Loy. I'm an Oregon Oral Health Coalition board member, and I'm also co-chair of the Early Childhood Caries Prevention Committee, which is, this is the first of what we hope to be quarterly lunch and learns of reconvening or actually a rebirth of the Early Childhood Caries Prevention Committee, which was meeting for quite a long time. And I'd like to give a little history of kind of what we've been up to for the past couple of years, as our focus has been mainly on the First Tooth program that was done in partnership with the Oregon Oral Health Program and OROC, and developing the medical dental collaborative learning tools that First Tooth uses and continues to use. You really can't adequately address early childhood caries prevention, though, without also addressing pregnancy and oral health during that important time. It was always the intent of the Early Childhood Caries Prevention Committee to have a pregnancy component. We hope to start that process now in collaboration with the committee members and a steering committee that is currently being built, has some members on it already, which includes myself, my other co-chair, which is Dr. Lisa Bazzetti for Virginia Garcia, Joanne Miller, who is sitting in the back, Zoe, who is also a OROC board member, Dr. Plunkett, Charity Ludwig, Linda Mann, Alyssa Franson, and Burl Fletcher, and we continue to build the steering committee because we very much hope to add some medical folks to that, because really this program will be modeled after First Tooth in light of the fact that medical dental collaborations allow us to, as a healthcare team, holistically work on oral health issues, including at this important time. The Lunch and Learns, which we hope to offer quarterly, are a way for us to present best practices, address your needs, so you will probably be surveyed to find out what are some of the challenges or things that you would like to learn about as it relates to oral health delivered during pregnancy. It won't be just a talk at you dynamic. We hope to have questions, networking time, allow people to try to work out challenges as we implement pregnancy and oral health in the actual healthcare team. So as we go forward, please think of that as the model that we're trying to build. Dr. Bazzetti was an early engager and on the steering committee of the First Tooth program, and so was I. We're trying to recreate some of that excitement that she said was really kind of cool to see as people came to the table with a lot of enthusiasm and really jazzed about trying to sort of tackle this early childhood caries issue of this preventable disease, this number one childhood chronic disease infection, in sort of a collaborative new way. And that's kind of what we hope to recreate amongst the reconvening of the committee, that we can then form an excited group. We can bring together some of the really positive, exciting things that have taken place nationwide regarding this particular issue and do it sort of Oregon's way. Oregon tends to sort of like to do things our way. So certainly it's not recreating the wheel, but it's tailoring the wheel to what it should look like and will be the best way to deliver care here at Oregon. It is certainly a hot topic. The New York Times recently had a newspaper article about it with the dismal message being experts say too many pregnant patients are not getting timely dental care because of outdated notions that treating them is not safe in other factors. Pregnancy is certainly and shouldn't be a reason not to provide oral health services. So the launch of these Lunch and Learns will really be around this particular document, which is the Oral Health Care During Pregnancy, a National Consensus Statement, a summary of expert work group meetings. In response to those experts' concerns, many people within the industry, both medical and dental, got together to say, let's put together a document that says what we can all agree to across all kinds of healthcare providers. And that means obstetricians, family practitioners, dental providers, whoever, so that we can have something to refer to that gives us clear indicators of what can be done during pregnancy, can address some of the provider issues that basically have kept pregnant women from getting the care they need, and build sort of a collaborative and consistent messaging of how we can outreach to women during this really important time during their life. Pregnant women are in a place sort of psychologically to be very receptive to messaging, so we want to definitely take advantage of that. What are some of the challenges as we go forward over this next year going to be? Some of the challenges in pregnant women getting the care they need are not all practitioners know or have bought into or have a consensus on dental care during pregnancy being safe. So we definitely want to share information that gets to that particular audience, both medical and dental. Many of the medical providers who are providing services during prenatal times don't necessarily include an oral health risk assessment. They are risk assessing for a lot of other things, but they haven't necessarily included that particular component. And oftentimes when someone sits down with them, it's like an aha moment happens and says, you know, it should be part of what I do. I can't believe I haven't been doing this. And how can we include it in a way that's not time-consuming and cumbersome? So it really is that we don't have receptive entities or parties in healthcare that want to do the best thing for their patients. We just need to together build the right information systems, build the right systems to support those interventions, and sort of wrap around the efforts that we hope to do in Oregon. The barriers also include, you know, taking these key concepts so that, you know, I know that Linda Mann from our organization is on a Head Start advisory group and wanted to just, you know, shrink when a dentist said, oh, you shouldn't have any dental services during pregnancy except emergency dental services. And he meant the best intentions by that, but that's not correct information. And so we want to make sure that we're messaging and giving clear indicators as healthcare professionals so that people, like the pregnant women and families we're trying to care for, will follow through on that. Many of these women are facing a lot of barriers, transportation, work, a lot of complexities during their pregnancy. Most of the disease is in some of our most socioeconomic challenged families, so we've got to address those barriers, and we want to reassure them that oral health during pregnancy is important, it's safe, and it's something they should follow through on. One of the other organizations that has been very active in pulling together information on early childhood caries is the American Academy of Pediatrics, including having a module of their own called Smiles for Life. Taken off of their particular program, the dental disconnect is talked about. Only 34% of pregnant women visit the dentist. The percent is even lower for those who are socioeconomically economic challenge. Only 50% of women with a dental problem go to the dentist. So that's hopefully something that through the next coming year we'll be able to address together. One of the barriers to this was there was no national consensus on what could or could not be done during pregnancy. So this document gives us a good platform to work through that. Medical clinicians don't always sometimes see their partnership role in both referral and risk assessment and talking with their pregnant women about oral health. Many dentists don't necessarily have best practices and information they need to realize that it's safe. And they may fear malpractice or other issues that really are not proving to be as substantive as what the clinicians might think. So what clinicians can do is promote oral health together with unified messaging and anticipatory guidance. We can increase the number of women who are screened routinely in their OB practice, share information, standardize office procedures so that we can take this information and make it effectively a practice. And what do we get to gain? Periodontal disease has some association with preterm and low birth weight babies. Pregnancy outcomes and oral health treatment during pregnancy is safe. If we decrease the mother's bacterial load because this disease is transmissible, we impact their baby's oral health. We can get the women the care they need when they need it, and that clinicians could ultimately have this just become a routine, easy part of their practice that isn't seen with all the issues of struggle that currently keep them from doing, including this in their routine care. We hope that you enjoy this, and we hope that you look forward to joining us future ones as we work through pregnancy and oral health.
Thanks, Deborah. I'm Gary Wappus. I'm the Executive Director for ORAC, and it's my pleasure to introduce our speaker today. To those of you that don't know him, Dr. Mike Plunkett is the Dental Director of Care Oregon and also an Assistant Professor at OHSU, and I know that Mike has been doing a lot of thoughtful work on this subject, and I know it's dear to his heart, so I'm looking forward to his insights. Mike.
Thanks. So I may stand if I need to see everybody, but first, before I even start, just say that part of the learn part is that you all have a lot to offer because you're on the ground working with various populations in different parts of the state every day. And so anytime you want to add something, ask a question, agree, disagree, or just create stimulating conversation, feel free to do so. That's the style I prefer. So like Deborah said, this presentation will be largely built around the consensus statement that came out just recently. I can say that this would be a very difficult presentation to put together with any sort of consensus or support a year ago would have been, but this document has given so many of us that have been thinking about this for a long time, the maternal-child continuum and the need to integrate more direct care and integrated care to pregnant women as part of the solution. Many of us have been thinking about this, have had trouble finding consensus and support to go out and convincingly and confidently say these things to large groups and feel like the profession is behind us. This consensus statement is really huge. I think it's going to do for this particular area what the bringing in the oral health into Healthy People 2010 did 10 to 13 years ago. Right, I'll just give you the nod. Okay, so a few things, a few slides about what we know. Quickly, we know pregnancy is characterized by some changes, obviously. Some lifestyle changes, physiological physiological changes, dietary changes, just generally speaking. I can say from having 2 children, everything you thought about life and the way it's going to be when pregnancy comes down the pipe completely changes. And so, not to mention the physiological effects. So we know inflammation is more probable during the pregnancy months. And so when you add in that bacteria that are caused by untreated dental decay and lack of knowledge of how to care for yourself through pregnancy from an oral health perspective, then that creates risk. Risk that doesn't stop with the woman who's carrying the child, baby, as it's born and goes into its early childhood years. And we also know that most dental treatment is safe throughout pregnancy. That risk lies more in not treating a pregnant woman who has dental disease of various types than in treating them. And there's actually an emerging body of legal knowledge around the flimsiness of saying you're going to get sued if you treat a pregnant woman. It just really is flimsy. There's just not a lot of evidence to support it. Unless, of course, you treat them to a standard of care that's not in best practice, which puts you at risk no matter what patient you're treating. So we also know from a biological standpoint, most young children acquire their bacteria in their mouth and much of their head and neck from the mother, because that's the first person that kisses them, that comes in contact with them. Remember, the baby's born basically effectively sterile. Their mouth is sterile, their lips are sterile, and they're inoculated, or the bacteria are introduced to their body by their caregivers. And when you think about oral health and who's putting food in their mouth, nipples, whatever it may be, food of any type, then that's typically the primary caregiver, which tends to be the mother. And we know that when you reduce the mother's dental disease, you lower the risk of disease in the child for several reasons. One, you're reducing the bacteria that cause the worst problems in early childhood in the mother's mouth, therefore the transmission is of a different type of bacteria. The other is just sort of the process of getting the care empowers the mother to make choices that are more amenable to good oral health outcomes. We know from evidence in multiple areas of the country, including some of the best here in Oregon, down in Klamath Falls, that counseling and case management dramatically reduces bacteria and dramatically reduces the risk of early childhood caries and disease. And we also know that if you focus your program solely on 1, 2, 3, 4, 5-year-olds, then you're not going to be nearly as effective as if you go back and you consider your program comprehensive by incorporating the maternal component and seeing the disease process as part of the maternal-child continuum, or I should say the empowerment to reduce disease rates as really a maternal-child continuum. There's really, I can't think of another area in health, well-being, and healthcare where you wouldn't start with the mother when you start thinking about pediatrics. I mean, the maternal component is essentially the bedrock of any overall health and wellness program aimed at young children. Really the family structure. So there are some concerns, reasons which Deborah talked about, which are many in the public just don't understand that it's valuable, and it is important to get dental care, dental services during pregnancy. There's a general belief that oral health is just the way it is. Your gums just swell, you just get more things happening with your mouth when you're pregnant. That's just the way it is. And anybody who's treated patients directly for any period of time has heard these things. It goes right there along when someone comes in and says, well, my mom or my dad had soft teeth and I got soft teeth. You hear these kinds of things, and these are things that build in people's mind as a perception of something that take trust and comprehensive programs to break through. So many just do not seek or receive oral health care during pregnancy by their own choice. Very, very few prenatal providers incorporate any type of oral health component into risk, education, their risk assessment, education of the mother, or any other of the programs that they do while during the pregnancy years. And maybe the most alarming is that if many dental providers still feel that way and they have an antiquated view of this subject, then it's going to be very difficult to move any program at the larger level. I was in a continuing education about a year and a half ago at OHSU around sedation and very complicated stuff, and the provider stood up and just said there's just no reason to treat a pregnant woman. It's just not. And he gave a story. Now, I don't know, could be 50, 60, 100 people in the room, And he says this, and then he tells a story, and it's based on that some woman spotted 20 years ago in his chair while he was doing treatment. And I said, this is a very smart person talking about complicated subjects. And then when we get on this subject, we go to this, this level of anecdotal decision-making that is just so far below the standard of care. And we had a very spirited discussion in a large audience that he was happy to get to the next subject. Just to remind him that he was in opposition to basically every advocacy body for women and children in the country, and so it was uncomfortable. So I'm not going to go through all this data mania, but this is a great slide. I think there are two things that stand out. One is how things are relatively unchanged over time, but really that the next to last, the one around non-dental providers, nurses, doctors, other care providers, how low that is. Yeah? Because if you're talking about eyes or ears or hair or skin, you're going to have those people incorporate. It's just going to be part of what they do. But they're just not talking about the mouth. The mouth is really what they look through to look at the tonsils and the throat. And they may be looking past things that contribute to more ear infections, nightly pain, missed school days, so on and so forth, right down the line. So incorporating more oral health into the just overall wellness care for a patient's wellness in multiple arenas is as important as getting the profession to move. We're thinking it's okay to treat pregnant women. Because we can't simply do this as the dental industry. It just ain't going to happen. It has to be a comprehensive thing. So what are some action steps? So first of all, to incorporate oral health components into prenatal visits so that it's an integral and important part of the practice of the OB practice. And when I say that, there really has to be incentive. When we're looking at maternal medical home, which many groups are piloting in the state as part of healthcare reform, there needs to be some accountability and some incentive for them to do this. Because if there's not, they're not going to add it on top of the other 50 things that they're being held accountable to as far as metrics in the maternal medical home.
Can I ask a question
Sure.
there? So Deborah,
You left on a high note.
oh.
Like, I'm out of here.
She might be able to help with this. But there's that screening code that can be used by medical providers for the 7 and under. Would it? That's the ideal thing for me. I think if we could say, if you add, so the screening code for medical providers is if you add the oral health element to the well-child visit, they can get it bumps up the well-child visit from this rate to this rate. I think it's $11 difference. Sure. But if it could be the same with the pregnant visit, that would be the incentive financially, and I don't know what the status on that is.
I don't know. The only thing I know about this, and we'll talk about in a second, is that some of the groups that are piloting maternal medical home, like Women's Healthcare Associates, have been very proactive in saying we want to add an oral health component. But I can tell you that, so let's say I'm running a big clinic group, or I'm part of it. It's a member-owned Women's Healthcare Associates. I think they're the largest maternal provider in the state. They're a member-owned private group. They're not going to ask to be held accountable for something like referral systems if they know they can't access the dental providers before they enter that conversation. So they first need to know there's a system in place for them to refer to and to navigate and to coordinate before they say they're willing to take on the risk. They might be willing to get an extra few dollars to incorporate this into some bundled payment, but to really move the needle, they have to see, education, direct counseling, and then referral. They have to see that when they do that there's actually an avenue to make it happen. So we'll coordinate care with the oral health delivery system from the prenatal provider, which was what I was just talking about. They have to have access to the networks being the providers and the groups that support the providers in some simple, effective, efficient way that is not adding too much administrative burden on what they already do if they're going to do this. Or you'll lose their attention span. They'll say they're interested, but after they've only got so many times for meetings to discuss on how to develop this, and they need someone to develop for them, come to them and say, now let's make this work. Support efforts to improve oral health services in the community. That's something as simple as when it comes time to discuss whether or not we're going to cut dental benefits in the state of Oregon. It'd be nice to have Women's Healthcare Associates sign on and say, that's a bad idea. Or to have the Children's Health Alliance say, if you do that, you're going to cut the benefits of the father, another caretaker, or an older brother, and that's going to introduce inconsistencies in this family's access to oral health. We don't have that now. And Deborah can speak to that as a road warrior of Oregon Health Plan talking about not cutting themselves, cut that person, but don't cut me. And they're too busy doing that to say, well, I'm happy for them to have money to have adult dental because it affects how we care for patients. So in the prenatal visit, perform basic oral health risk assessment at the initial visit, reassure women that oral health care is safe, integrate oral health education in the prenatal classes, and then provide oral health education for all these things. The links to overall health, importance of good health during pregnancy, and how bacteria from the mom's mouth will affect the baby. All these things just aren't done now. They're just not. Unless it's a really adventurous MA or nurse that's doing the initial intake that says, this is really important, we'll talk about that. But they're probably not, because they're trying to get to the list of things they need to do. And unless you formally incorporate this into their system and incentivize it in some way, usually payment, then they're just not going to do it. But it doesn't take much. I mean, this is a slide. I think you can pretty quickly have an algorithm of a few questions where you engage the patient to ensure them that it's important. And then you have very, very succinct materials for their own education. But like Deborah said, with this, the idea from a behavioral health standpoint, we've known for years with for health promotion and prevention that the single group that is most susceptible to behavioral change are pregnant women if they think their behavior hurts the baby. Otherwise, you can tell adults something's hurting them over and over and over, and until you make it painful from a financial standpoint or some other. They're just not going to quit doing bad health behaviors once they've started. But as a group, pregnant women are the most susceptible to behavior change if they think that last thing is going to happen, that it's going to affect the baby. So this is from Women's Healthcare Associates, but they now have an oral health component added. I should have updated it, but it's very simple. Do you see a dentist? Do you have a dentist? I don't want to misread. It's two questions, effectively. One around, do you brush frequently or do you have dental care? And either yes or no, they get from the oral health program a very simple one-pager that talks about the importance of oral health. The second is, do you have current issues that you need care now? And then there's an education component, but that will lead into, hopefully in the future, after we sort of dust settles on integration of dental and everyone sort of knows the rules of the road, we can start developing some quality improvement projects to ensure that those women that identify that they want to access services can get it from point of service in an OB office to the dental practice that is appropriate for them. But you see, this is a very small snippet of 2 or 3 pages. I mean, there's so much. There's the behavioral health component, there's the overall health component. So you see, just by looking at a quarter of one page, it has to be quick, efficient, and salient to what they're doing every day, or they're just not going to add 5 lines of dental stuff, especially when they just don't know anything about it because they've never done it. It has to be simple and easy. So some referral, this is just some things, some brainstorming on how this might look directly from OB to dental office. That's really where you're talking about point of contact, provider to OB. And this becomes much, I think, more efficient and easy to do in areas that are not as concentrated population centers, where you, for instance, have one big dental plan, 1 or 2 big medical plans, maybe a CCO, where you can really line up those networks. When you have, 8 dental and health share with 4 rays and family care, and there's all this competition, it makes this very complicated. But you can really pilot this in more scaled environments, I think. OB, DCO, dental office, this becomes a little more feasible as the population gets more complicated because the DCO is managing the panel of providers. So the DCO can identify those providers that's very interested in doing this kind of work, because not all are. OB, referral hub, dental network, this is something that Deborah and I and others have been looking at, really brainstorming on ways to create some sort of referral hub with existing structures so that it could be a single point of contact for groups, well, maybe well beyond OBs, I'm not sure. I mean, it could be EDs, could be Head Starts, but something that's efficient, effective, that really coordinates the care rather than having so many administrative structures that people in the public have to access between services, making it more simple so that the patient gets to the appropriate place. And then OB, DCO, dental network. That would be where if a CCO was just directly contracting with a dental network, which could be, a possibility in some areas of the state in the future. And from dental providers, necessary collaboration with prenatal providers, establishing relationships office to office, participate in formal referral processes. Honestly, that's probably the biggest part. If you're an office and you're taking referrals, or people are calling their insurance company and getting you off of a list or a DCO or whatever it may be. It's that formal referral process that you can operationalize, and it becomes automatic. So every single case is not a one-off or ad hoc thing that really puts a burden on the day-to-day work, but you actually feel like there's incentive to operationalize into your organizations or into those clinics a direct relationship. You coordinate care, consult with prenatal care health professionals as necessary, and that's all over the place. I mean, I could sit here and regale stories for an hour about patients that I've been seeing in the last 6 months. High-risk pregnancies where it's a neonatologist, and just routine pregnancies where I'm working with an OB, but they're mixed messages all over the place. Just trying to standardize some of that so that everybody understands what's appropriate and what's safe, and the patient's not getting mixed messages. Guidance for oral health professionals. From a care, we don't want to get down in the weeds here, but really seeing it from a disease management standpoint and not just jumping in. And you've got a window of time. The first trimester really is when everything's developing and a whole lot is happening in the pregnant mother's life. That's a great time to do education, counseling, basic diagnostic, and treatment. The second trimester is time when there's least effects on the development, but also it's most comfortable sitting in the dental chair, and probably less going on than when you get into the trimester. As you get closer to the birth, the lifestyle becomes more complicated because of maybe increased visits, and positioning gets difficult, sleeplessness because of positioning. So really there's sort of I wouldn't call it an algorithm, but there really are guidelines around treatment that make it easier for the mom to get the care she needs. And that makes it important to find providers that are willing to throw in and really educate themselves and partner toward that type of care. And discuss the benefits and risks associated with treatment. Just use standard clinical practice. Be aware of guidelines. Just like I said, there are guidelines around trimesters and what's appropriate and what's recommended. Positioning is huge, and follow-up after treatment. Care management, ensuring that your patient understands in the office or that you're advocating behalf of in a non-clinical environment, knows all the choices and understands the administrative work. And I think that the Head Start folks in the room can speak to this from a different standpoint. It's just that in a very busy life and a very busy organization, sometimes that just the administrative part of accessing services can be a deterrent just because it's so complicated, especially when there are a lot of companies doing the service. So in conclusions, good oral health is essential to a healthy pregnancy. Mother's oral health status and knowledge are directly affect the baby and are important. Oral health must be integrated into prenatal physical health if we're going to move the bar on this. And the care coordination between the provider groups is very important. And dental providers should provide appropriate care to women in their pregnancy. So one thing that Karen and I talked about at it'd be great if Karen could talk to you now a little bit about, since our summit meeting, and this is largely a reiteration of that presentation with some minor changes. But since that time, the supportive activity has been going on, whether it be the first two, the childhood Carrie's group that's getting together, and maybe Karen could speak a little bit about the incorporation of maternal health into what's been going on in early childhood for some time.
Yeah, sure. So the Oregon Oral Health Coalition has really taken on this as like, oh, this is maybe another track that we can include with the first two tracks that we have. So it's not necessarily battling against it, but it would work in conjunction with it. We have had, over the last 3 years, in our first tooth evaluation forms, a lot of times people say, oh, I want more information about oral health and pregnancy and that sort of thing. So that also was a reason why we started talking about this. And when this consensus statement came out, it seems like this is the perfect time. People are becoming more aware, and maybe this is a great time to develop that more pregnancy track. So we decided as a group to go ahead and get started on that presentation. I'm going to try to keep it at about 45 minutes. That way people can have it, like more of a lunch and learn type organization instead of like an hour and a half like the first two thing is. But in addition to providing just the education, that's going to be very similar because I'm going to take, I've already started taking the information off of this directly, including some other organizations like the Smiles for Life or the Perinatal Oral Health, COHP, whatever. And then Washington Dental Service also has a really great track for pregnancy. So kind of like in the development of First Tooth, kind of looking at all the different really great programs that are established out there and determining the best practice, picking and choosing, making it Oregon specific, like First Tooth was. And like First Tooth, we also want to make sure that we have a lot of hands-on and practical stuff for them. So we gave you guys handouts of some of the things that we're thinking about. This is what we already put into First Tooth, just kind of, since I just barely touched in the First Tooth project on oral health, I encourage people to open this up and look at this. So we'll probably continue to use this in the pregnancy track. This is also something, this came out of the consensus statement, but it kind of summarizes some of the medications that medical and dental providers would likely prescribe, and it talks about the safety and then ones that you would be a little bit more cautious and what kinds of pregnancy. So something like this, similar to this, is not this exact one. And then you guys are familiar with the First Tooth materials. We have like an American Academy of Pediatrics split book that just kind of sits on it stands up and it sits, and it's a great educational tool. It has pictures on one side and more words and education on the other side, and we'd like to have something similar to that so that medical providers or other people have something easy to use to educate their pregnant women. And so I've been really working hard at trying to find, Phil and I actually have been researching about everything we can find on pregnancy brochures that you hand out to patients, and I want to recreate that into a flip book style. So I'm working on that. It's been a challenge. But some of the main challenges that I found when I've been trying to research materials is that a lot of this stuff seems to be a higher health literacy than I am comfortable with. So there's a lot of information, even from these guys. They have handouts and stuff, but if you guys are, really watch health literacy, a lot of it looks about like this in smaller print and in a smaller handout. So that's, you health literacy people know that just isn't going to work for the population of patients that are our biggest challenge. And so I've been trying to find something that's got a little bit more simple language, maybe so that we can offer something for patients that are at a higher oral health literacy and for patients that are at a lower health literacy. So if you guys could, if you find something that you really like, that the message is good, it's consistent, it's accurate, but that has a little bit lower oral health literacy for me, I would love to look at that and, maybe utilize that in our toolkit. So we're going to provide in the toolkit, handouts. We're going to provide flip books, very similar to what we do for First Tooth. The toolkit won't be exactly the same, but giving people real hands-down, this is how you can implement this in your OB practice. Also working a lot, like Mike said, on that, figuring out how to create a formal process for referrals so that it's easy. And I think I'm going to really work with Heidi on how to implement just some of those risk assessment type questions, because you did a lot of that, and Sarah did a lot of that with First Tooth in your clinic. And so it would be great to get some of that input on how can we do that for the risk assessment for the prenatal visit too. Implement some of those easy, quick questions that will just automatically build into the smart phrases so that the provider doesn't have to think. They're just like, okay, got to ask that question, got to ask that question. And then maybe even they get zipped off to a certain pool where, I'm not really good at that EHR stuff. But anyway, I'm really going to rely on some of you guys that have implemented system-wide changes to help out on that. So anyway, anything else that I need to touch on? Do you guys have any questions about how we're going to really work this into ORAC?
Is this timely? Is this something that is going to be a value? Again, we're trying to create this so that it is something that works at the front line. So is this something that we've had questions come, like I said, from First Tooth to Karen. We've had various, even coordinated care organizations say that they would like to include oral health in pregnancy. They don't really know how to do that, how to take that next step. And want to definitely make this something that is going to be able to.
Yeah, so some of you that work, do you think that you're in an organization? How about you, Heidi? And Joanne, what about you? Do you think that this is something that would be interesting for the providers you work with?
Lebanon Hospital is bilingual, bicultural, has just taken this by leaps and bounds to make certain that all of her patients are well aware of the importance of oral health and even promote the first two.
I'd be interested in what she's using, if you don't mind picking me up with her. That would be great. That's a helpful. Okay.
So is modeling it after, like, the first tooth kiss? Is that a good thing for the field? Like, I mean, like the little flip books and all those things that Karen mentioned that are tools so that practitioners and people that work with folks can use those? Is that a good pathway to take?
It was very helpful with first tooth because we were able to take out of the kit what would work best for our situation. And we didn't use everything, but what we did use has been extremely helpful with both getting the providers on board and then for patient education as it goes on. So we've had a really, really good starting point with having the kit all there and set and ready for you.
Who do you represent?
Metropolitan Pediatrics.
I think the other thing that we're wanting to, because it really, although the disease is done more in socioeconomic challenged populations, good oral health in pregnancy is best practice, period. So trying to also create something that isn't just a Medicaid kind of thing, but something that can be incorporated into practices for all patients.
Well, I know right now Providence is trialing a new pregnancy program with support groups, group office visits, things like that. And they're just going through their first group of women, and it's not something that's set in stone yet. But I'm wondering if maybe getting this oral health piece into that, which I think they're planning to go system-wide with it eventually, but right now just in trials, to have that as part of the regular, we'll do a group visit to the dentist office as well as doing it to your office, putting it in the schedule and getting that as a regular routine.
That's great. Do you have a contact?
I don't with me, but I can find it out and get it to Karen. Yeah.
Great, thanks. That'd be great. Really, we're in this together. That's really what this reading meeting is about. And the steering committee is being built, so we definitely, when first two steering committee included a pediatrician who was very, very passionate about oral health and for kids, and that really made a difference. And it's not just about the medical side, it's about the dental side. So many of us are better equipped to speak on the dental side because we're coming from the dental field where we really need that voice champions and kind of that, the medical people that are going to make this, help make this reality in practice. So if you know any of those folks, we very much are open to building kind of a steering committee with that.
Karen, go ahead.
I was wondering if it would be possible to incorporate a simple basic question into the vital signs, because every pregnant woman comes in and has her blood pressure taken and her weight and anything else like that. And if it was just one more question there, and then like you're saying, then you could segment it off. You know, have you been to the dentist in the last 6 months? Are you having any problems with your mouth? And then go the direction you need to go from there. Stickers on the chart or flags on the stickers on the chart. But you know, something that would highlight that you've had that conversation, that initial conversation, so the next person can pick it up a little bit. That's a good idea.
I think the only way you can incorporate those types of things into standard medical practice is if the medical group. So Providence is a great example. Providence has got navigators through EDs. They have maternal health coordinators. And the reason is they're so focused strategically on becoming being seen as an ACO, accountable care organization, of all the states in which they function. That means that they want everyone to look to them in a place that that they are accountable for the overall health of every patient that comes into the Providence system. And until they see oral health, indeed, in emergency departments they do. They've been pretty aggressive at developing partnerships there. But until they see oral health is something that is going to be valuable in that accountable care organization system, and that's really getting the metrics lined up so that Providence Health System, even though they don't deliver dental services, access to dental service. We incorporate dental services. We're not quite there yet. The dust is not quite settled on how dental comes into the CCOs and then later on other groups like OLED and PEB and how those things. But I think that there is possibility for those things, but those systems have to see an incentive long-term strategically to incorporate some all up into what they do every day.
I see it correlating a little bit like smoking cessation, because there's a financial reward and a physical reward to smoking cessation and addressing any smoker with a flip chart or educational opportunity and patches or whatever they need. And if you correlate the health of the baby and the health of the mother to the bacteria that's in the mouth, then that would be a healthy baby is a lot cheaper than having a sick baby.
All right.
I'm new to this group, so I give that caveat. But I'm wondering, in my experience, given this is anecdotal, so getting Medicaid pregnant women an appointment, was the challenge. I mean, largely our wait, this is in Multnomah County. I mean, they couldn't get in for, 6 months, 7 months. Is that part of the, well, I guess my question is that an issue, really, or is it my experience, and is that part of what this is wants to work on?
I don't know of any. I know the dental system pretty well, but I just don't know any place where you have to wait 6 months for an appointment. But if your experience is your experience, it needs to be addressed.
Yeah. I mean, I think there's some, this is women I work with who are, difficult to get them to follow through with appointments, difficult to get they can't show up at any 8 o'clock appointment, like many of those are issues. Well, now I work for the state public health division, but that was when I was in Multnomah County, the health department, doing home visiting. Right, and that's where it was hard to get it in, hard to get it in.
I had invited Andrea Witherspoon. She's from Family Building Blocks and Early History. And just a couple of weeks ago, we had an email conversation about some of the barriers around her pregnant clients getting care. So if you wouldn't mind sharing what. Yeah.
So I work for a Head Start program, and I think we're sort of in a unique opportunity to be alongside prenatal moms who are working with maybe like a medical provider and then also trying to find things like that. So I think having some messages for our home visitors that we can give to those moms that aren't necessarily medical professionals, but who are in that place where they can kind of feel alongside that mom when she's trying to navigate the system. And then I think also just sort of the barrier of undocumented prenatal moms that we work with, and how that looks much different than like the moms who are covered under OHP. So yeah, just some other ways that we can support them with that.
So I think both Mike and I talked a little bit about developing some kind of referral system. And it could be a single phone number that's able to box or form handoffs to the right places. Some of the, and making sure it's not just about medication, but, what are the options for all women so that we can have this more holistic approach to pregnancy and oral health. So that's definitely, as we survey all of you and say, what are the issues you want us to delve into, work through? I think even at first, too, Karen's gone out there and trained, getting children in to see the residents for the first visit by age 1 has been an issue and question that she's had to respond to, and building sort of the right knowledge to respond to that. So certainly that's part of what we intend to do. There's no sense in creating a program that you'll lose interest in that program pretty quickly if it isn't a partnership between the oral health delivery system and the medical delivery system together.
So Karen, maybe the flip book could not just be directed towards medical providers, but kind of like what we did with the Head Start.
Right.
Flip book, I agree. Make one that Head Start workers and early Head Start workers could use when they're doing and Healthy Start people, anyone working with pregnant women that don't have the medical or dental
worksheet brochure, and I feel like it could be made into a flip book, and so I've been trying to contact the people. I've been getting the runaround of who needs to give me permission to use it. But I was hoping to have it, and it'll be more like that, the AAP one that's big, that you could be used. Like, you guys use that sort of thing, right, for that sort of population, for the, like, the home visiting educators sort of people. And then what I'm wanting to do with it is create tabs that, you know, like a nutrition tab, oral health tab, you know, that kind of summarizes. And the one I want to use is going to be probably end up being about 12 pages long, but I'm not sure if I get the rights to do it. So, but yeah, that make sure that it's good for medical, dental, and for workers, so we just have one.
I think your groups are going to be about part of what we did do with its materials and sort of tested in this audience first before we took it, you know, mainstream and bigger. And so it really are going to be a valuable input to helping us make sure that we get culturally sensitive, correct literacy levels, things that are easy to feedback as we develop them on. So are we, people that are on the audio or whatever, are they able to ask questions? Or
They are able to ask questions.
Okay. Have you given them an opportunity?
I sent them a note and told them if they wanted to make comments or ask questions, go ahead.
Okay.
It should come through the conference note.
So do any of our phone folks, do you have any input or challenges or concerns you'd like us to address as we go forward in sort of building this? Super quiet. Is it helpful to think about having quarterly sort of lunch and learns with networking opportunities and an opportunity to, you know, kind of discuss challenges with people that can potentially, you know, get feedback or problem solve together with you? Does that seem like that might be a good forum to try to move forward in? We're actually pretty open to, and also open to having people on the steering committee as we address certain issues. So maybe, you know, like an obstetrician might want to be part of a certain part of it, but doesn't want to be there all the time. So also having sort of advisory members for the department. So if you have an interest, and definitely we're looking for more of the medical side complement to that. Please let us know. And with both our website and kind of new technology capabilities, we're also hoping to have this mechanism to attend these by not necessarily in person. So making it hopefully easier for clinical people to sort of do this and not have to give up so much of their time. Some speaker types that we've been thinking of is actually trying to get the gal from Washington State. They launched a program up there and find out kind of how theirs is going so that we can learn from her. Obstetricians are getting an obstetrician talk. Also, one of the main concerns for dentists is often surrounding concerns about malpractice, and both the American Academy of Pediatrics Conference and I think at the National Oral Health, a person from the insurance industry spoke on the non-existence of the lawsuits that they've been able to find. So helping to provide information that can work through some of the concerns or barriers that are keeping practitioners from the
We'll be, in the near future, we'll be sending out a survey to you with, among other things, that kind of question, what you think good topics and directions are, and your feedback on the process and including Mike's slides, will be available on our website soon, next week, and Phil will send you out an email, let you know when that's there. So please feel free to share that with others too, so that we can kind of spread the word on this thing. And certainly, when you get invited to the next of these sessions, feel free to forward that to other folks too. But, get a broader perspective. That's always helpful for us. I'm real pleased with I think all told, including people on the phone, we had 36 or 7 people come to this first meeting. So we're pleased with that, and we thank you all for your participation. I would mention the next 2. I think we have dates set for the next 2: September 11th and December 11th. So easy numbers to remember. And you will certainly get notified. So we hope that you can take part in those too, and we'll build those agendas off of what we hear from you on the surveys. So please do get back to us with your thoughts when we get that out to you.
And include on the survey if somebody is interested or has somebody we think might be good to add to the steering committee, and look through each of the packets, including the consensus statement, to sort of build